Well, like, we were talking about all their
I'm gonna wait. I don't know.
I don't think you should get checked out all the we have like so I have 4 worlds. We have the wow, when's the last time you oh my gosh, please put it out there. No, it's fine. Also, what is that? What's that picture? No. was just
No, it's just, I told him what to do. He said, was it funny? I'm like, okay, let's pick up with azoles. And so the next 9 pages are over antifungals. So this is something I added in today. I don't have any objectives over the azoles, so I will add those. Okay, so azoles and amphotericin B, those are our big antifungal guns. The azoles can be PO, and there are IV formulations as well. So they've done you a big favor. They all end in azoles. That's why everybody calls them that. So you'll see that there are triazoles. Those are the more newer. The imidazole, ketoconazole is an older product because it causes lots of problems, lots of GI or hepatotoxicity, GI distress, lots of drug interactions. Most of the time it's a more second line. So we usually use the imidazoles more. Nystatin is another drug that is in this, it's not an azole, but it's another antifungal, but we use it mostly topically, so it doesn't show up here. So all of the antifungals will affect some part of the fungus wall. And they'll usually bind to one of the sterols, and they will render it incompetent, and eventually all the contents leak out and the fungus dies. So that's how most of them work, very similarly. I have put down I've made you several tables. So the first one's spectrum activity, the next one is pharmacokinetics, because it's really different, and the third one is adverse drug reactions. So again, I'm trying to, I would say, learn what's common to all and then what's different. I can tell you that this class could be no different than anything else. Most classes of drugs are fairly similar. The drugs kind of do all the same thing. In this class, they all have the same mechanism, but they are so different. So I've highlighted some of the areas where the biggest differences are. If you look at the first 5, from fluconazole and that down to isufenconazole, you get broader and broader spectrum as you go down. We're going to see these drugs over and over again. We're going to see them when we talk about vaginal candidiasis. We're going to see it when we talk about nail fungus in general. So fluconazole, yeast, Candida, we're very good against Candida. That's why we use a lot with vaginal candidiasis. And also Cryptococcus. That's about it. So usually it's oral. It's usually in those areas. As you get down to itraconazole and the other 3, they get broader and broader spectrum. So kind of look at the things you start adding. Aspergillus, nasty bug. So that starts to show up when you get to itraconazole. And then you start to see the other molds being added. And then you see the mucorales added with the last 2. So broader, you know, the fungus kingdom is very broad, has many members, many families in it. You've got yeast, and you've got the molds, and so you have a varied grouping of organisms that you're trying to hit. So I would say that's what I would know, is that posaconazole and isufenconazole are the most broad spectrum. Okay, look at the next page. I put this in here because they are so different. And I highlighted some of the big differences between absorption and bioavailability. So if you look, fluconazole, very bioavailable. Look at voriconazole, very bioavailable. The others have different needs. So some of it is looking at, do they need to be given with a meal or not? Does stomach acid is it needed or is it destructive? Look at isubicondazole. It's a prodrug, which means what? Is it the active drug? No, it has to be converted by what? Usually the liver into the active. So that one's a prodrug. Posaconazole has a absorption saturation. I don't know of any other drug that does that. I was trying to think about that. But that one, the more frequent you give it, the higher the serum levels are. And if you exceed 800 milligrams, you saturate absorption sites. I don't know of any drugs that do that. So those are kind of the differences. You'll see those that need an empty stomach or a more acidic environment, you'll see they will recommend giving it with Coke or a soda or cranberry juice to increase the acidity. Avoiding proton pump inhibitors, antacids, H2 receptor antagonists would be important. If you look down through distribution, these drugs are very widely have a wide distribution. So what does that tell you? What would be the implications of having a very wide or large volume of distribution?
Adverse systemic side effects.
Oh, yeah.
Okay, not the way I thought you would go, but okay, perhaps.
Would it affect the
Who said that? Say it again.
Wouldn't it be good because you could hit a lot of areas? So
Yes, so they will hit fungus in most of the body. Not all of them. Some of them have good penetration into the eye, but not the brain. But for the most part, they get throughout the body. But there are some regional differences that where they are different. Those I'm not asking you to know. Half-life. Look down the half-life column. What do you see? Long. So they usually can be dosed daily. They are, if you look down at isubicondazole, 130 hours. Very long. Okay. Ketoconazole is different. It's an 8 hours, so it's very different in that group. Look at voriconazole, nonlinear kinetics. What does that mean? Linear? As you increase the dose, you get a proportional increase in serum concentration. Remember the post office? So as you increase the dose, you get a disproportionate change in the serum concentration. Okay? Here, it's all the same. Whether I go here to here, here to here, change over here is the same. Sorry. Serum concentrations. If I increase it by 5 milligrams, I get a 1% change. If I increase 5 here, I get another 1% change. Just as a here to there, change in serum concentration changes. Okay. The reason to know that is that you make a small change in dose, you get a big change in serum concentration, so toxicity goes up. Okay? So that one is to keep in mind. With that one, as you get at the higher end, 50% change in dose gives you 150% change in serum concentration.
So why would you use that one instead of different options if it has that toxicity change?
Well, one is it's very bioavailable. The problem if you go to itraconazole, it's so variable in terms of everything that affects bioavailability is very hard to predict. That one has very good bioavailability. It has penetration. I didn't put all the different penetrations. It penetrates some areas of the body better than others. So that's how they usually will differ. Pretty good thought. Last one, metabolism and excretion. Most of them are Well, I can't say that. Fluconazole is the body eliminates the with the kidneys. Itraconazole is metabolized by the 3A system. It has an active metabolite. It's the only one. The active metabolite of that drug is equal to the parent drug. Look at voriconazole. It's metabolized by 2C19, 2C9, 3A4. Big inhibitor of 3A4. Lots of drug interactions. Drugs that will impact its metabolism, and it will impact the metabolism of other drugs. Look at posaconazole. It's excreted unchanged in the feces. The GI tract gets rid of most of it. Minimal liver metabolism. So that one might be a benefit in people who have liver impairment. Isovuconazole is highly dependent on 3A4, so things that induce it, 3A4, or inhibit 3A4 metabolism are going to have big impact on that drug. So somewhere on that piece of paper you need to write, anytime you add an azole or you take it away from a regimen, you have to think drug interactions. They are huge. They're one of the biggest group of drugs that impacts. They're not the only one, but they're a big one. And they can greatly increase the amount of drug that is available from like if you put it with a statin. Mixing a statin with one of these azoles greatly increases the amount of statin that is in the body. And that can lead to breakdown in muscle, lead down to big muscle breakdown, renal failure. Okay? So these are not insignificant interactions. So you need to think big red flag, azole, red flag. Look it up. Get a pharmacist who can help you. So if you have, I haven't looked at Hippocrates, I use Lexicomp. So Lexicomp has a drug interaction online that you can look up. And one of these days where I don't have such a packed content, I'll bring those and we'll just look at what they'll tell you. So usually these programs, you put in the 2 drugs that you're concerned about, and it will bring you up and it will rank the interaction. It will tell you, is it moderate, nothing, minimal, moderate, severe. It will also tell you, does it happen right away? Does it happen a week later? And it usually will give you a synopsis of the literature. And then it will also tell you, here's what you need to do. Decrease the drug, just monitor, something along that line. Change to something else. Next page are side effects. All of these drugs cause GI upset. Most common is itraconazole. They all can cause hepatotoxicity. So one of the things you're going to do is you're going to monitor serum concentrations of their liver functions. So their ALT, AST would be the most common. Then 2 of them, the last 3 columns are more unique. And they're not going to be very common things that are going to happen, but they're kind of unique to the drug. So alopecia can occur with fluconazole and voriconazole. What's alopecia? Hair falls out. Not pretty. The next one is hypokalemia and peripheral edema with itraconazole and isovuconazole. Then the most unique are listed in that last, where they're mostly just for one of the, like chaplets with fluconazole. The one you really need to circle is voriconazole. It's neurologic toxicity. And it can cause visual change and it can cause neurotoxicity. They are not the same. They're two separate, 2 different side effects. So the neurologic change, they can have visual and auditory hallucinations. Agitation, myoclonic movement, so seizure-like type. Difficulty thinking, difficulty concentrating, difficulty processing information. And then nephrotoxicity. Okay. So I would learn what's the same for all, what's the unique for each. In terms of dosing, there is no rhyme or reason. I have to look them up because it's dependent on what's the indication, what's the severity, and what the formulation you're using. Here is a principle to keep in mind with this category of drug. It may have a suspension, a capsule, and an IV form. They are not interchangeable. If you got them on a capsule, you can't convert them to an equivalent dose. Okay, so that's important to keep in mind. If you're switching from IV to PO, you've got to do a different dosing change. There'll be a different dose recommendation. So I always have to look them up because I don't use these very often. So keep that general principle in mind. The other is that voriconazole, posaconazole, and isuvaconazole all required a loading dose for PO or IV. Now, what is a loading dose? We talked about these in the very first one.
The first is high.
Say what?
It's like a really large first dose, and then after that it's just more.
It's a large first dose, and then we go to a maintenance dose. But why do we do that? Saturate receptors. What else?
Bring them to therapeutic level.
Do what?
Bring them to therapeutic level.
Yeah. So we're trying to get them up to a therapeutic concentration. Some of it is because their volumes of distribution are huge. So if you don't do that, it takes them much, much longer to get to effect. So remember when we were talking about steady state? What's that stuff? Okay, so steady state, how many half-lives does it take to get to steady state? So if you got a really long half-life, like 130 hours, how long does it take you to get to steady state?
Long time.
130 hours. Okay, so a loading dose helps fill up that volume of distribution, helps you to get to this point much faster. So they require a loading dose, and those are package insert would tell you, Hippocrates would tell you those. Monitoring. So you should remember if I've got liver toxicity is a problem, I'm going to have to monitor liver level or liver transaminases. For some of them, we talked about hypokalemia being a problem, so we monitor potassium, fluid levels, edema present. Neurologic changes would be with voriconazole. These drugs can be serum levels can be measured. So if we know that when the drug gets into this range, we get the best effect. This is the therapeutic range, we call it. And we can correlate a serum concentration with therapeutic effect, then we'll monitor levels. We don't do it with all drugs. So with these drugs, we can actually sample. And we can say if they're in the range that we're looking for, then we'll get the expected outcome we want. Not all drugs do that. But these you can. It would also be not only for therapeutic, but most of their bad side effects come when they're above the therapeutic range. So that would be another reason we would look at that. The other is drug interaction. Drug interactions. So drugs that induce metabolism, rifampin, the anticonvulsants, notorious. They will increase metabolisms of the azole, and so they'll be less effective. And you may have treatment failure. So when you're treating a fungal infection, a pervasive, a systemic fungal infection, that could be bad. Okay, so we wouldn't want to use those drugs together. Or if we did, we would adjust the dose so that we could overcome the induction. The azoles are big on the 3A4 system, the inhibitors. 3A4 metabolizes the majority of drugs that we have, so that's why I'm telling you, you gotta look them up. Okay, questions about the azoles? They're nice because they are, and you'll see when we compare them to amphotericin was the only drug we had for eons for fungal infections. It is a very toxic drug to use. And so until the azoles came along, we killed off a lot of kidneys because of that drug. We could save them from the fungal infection, but we killed their kidneys in the treatment. So when these came along, they're huge. They give you an alternative. So some of them are IV, so we can use them IV and treat an invasive fungal infection, or for a more mild, we can give a PO. So the azoles were a big step forward in treating fungal infections. Okay, so let's talk about amphotericin B. Very, very potent drug. Only should be reserved for diseases that cannot be treated by the azoles. So severe, resistant, invasive, severe systemic fungal infections, this drug can tackle it. But because of its toxicities, that's who we're going to reserve it for. Should not be used for non-invasive forms or non-severe. Spectrum is extremely broad. If there's a fungus in you, it will kill it. There's the ones that are listed. Look at the bottom of that page. So one of the big things to look at, and we will revisit this drug again in Durham, not in Durham, in ID module. The formulations make a big difference. So the old traditional amphotericin B, the deoxycholate, is called the conventional. Because it is the one most nephrotoxic, they came up with different formulations and they added lipids to them. And that made them easier on the kidney. And there's two different types. There's the amphotericin B lipid complex and the liposomal amphotericin B. They are not interchangeable. Their dosing requirements are different, and people have overdosed folks by using the conventional, or using the liposomal dosage recommendations for the conventional. So when if you're ever going to use them, you've got to know what formulation you're dealing with, or what the hospital is going to provide. Okay, so that's circle it. Big concept, Latassi said, pay attention to it. So let's look on page 21. So let's look at the amphotericin deoxycholate. So you do not have to know the dose here, but look at it. It's a half of a milligram to 1.5 milligrams per kilo per day. We try to use the lowest dose because the lowest dose is less nephrotoxic. Another concept with this drug is that the dose is cumulative. So the longer you have to give it and the more you give, higher cumulative doses are more nephrotoxic. When you reach about 600 milligrams in cumulative dose over the course of the treatment, then the risk of nephrotoxicity goes up quite a bit. So cumulative dose. So we have a few drugs. A lot of the chemotherapy drugs have cumulative dose toxicities. We won't see it with a lot of drugs that we talk about this year, but this is one of them. There are lots of ways to give amphotericin. We're just going to look at the IV. But it can be if we get a fungal infection in the bladder, we can do a bladder installation. If we get a fungal infection in the peritoneal space, we can just infuse it in there. We can spray it up or have people inhale it, or we can give it IV. We're going to look at the adverse effects because they are significant. Infusion-related bad effects are very common. So we usually will pre-treat them in order to decrease their effects. So nausea, vomiting, chills, rigors, those are very common. They can occur while they're being infused or after the infusion stops. Usually with a lot of infusion reactions, if you slow down and you give the infusion over a longer period of time, usually that will help with a lot of infusion reactions for a lot of drugs. For pre-treatment here, we use Tylenol, hydrocortisone, and diphenhydramine. If they tend to get nauseated with the infusion, then you can use an antiemetic, and there's a broad, promethazine very common, prochlorperazine, ondansetron. Phlebitis, what's phlebitis? Not clotting, what's itis? Inflammation. This is of the vein. So it's very common when you put a you ever had an IV? Okay, so it's very common for drugs that we put through an IV site to irritate the vein. So phlebitis is that inflammation, okay? So amphotericin is really hard on the veins. So we can put it through a central line, bigger volume, bigger vessel, doesn't cause as much trouble. We can alternate infusion sites, that helps. We can give small concentrations, so we can dilute it out, and that helps. That helps with a lot of different drugs we give IV. And we give it over a long period of time. So dilute over long periods of time and switch your sites. Next page, drug-induced fever, chills, headaches. Usually your pre-medication drugs will help with this. Tylenol, the diphenhydramine, you can use non-steroidal if you don't want to use Tylenol. Nephrotoxicity, very common. In fact, we're going to expand that after we talk about the lipid formulations. Very, very common. So you're going to monitor serum creatinines when you've got people on amphotericin. Usually it is mild, it's reversible. Most of the time we'll allow people to stay on it unless their serum creatinine goes above 2.5 or rises by more than 2.5. So that will be something you would do almost daily. What is a normal serum creatinine? Have you talked about serum creatinines? Oh, surely you have on a basic metabolic panel. You haven't done BMPs? Yeah.
No.
Okay. Serum creatinine. Now, it will vary, but you can just kind of keep in mind 0.6 milligrams per it's per deciliter, up to 1.0. That's pretty normal. Some you'll see go up to 1.2. So remember, about 0.5 to 1 is normal. Keep it in mind because we're going to talk about creatinine clearance until your eyeballs roll back in your head when we're talking about drug use. Okay. So we're going to be watching that. The ways we can try to prevent that is we can keep on volume, we're going to keep them hydrated. Not use other nephrotoxic drugs. So keep that big concept as we go through and talk about like aminoglycosides, other drugs that are hard on the kidneys, chemotherapy, very common. The amphotericin B deoxycholate is the most nephrotoxic. It's thought that the deoxycholate, which is actually a detergent type additive that is given, is what makes it more nephrotoxic. So amphotericin B deoxycholate, the worst. The liposomal amphotericin B, the least. Then electrolyte abnormalities, so keep these in mind, low potassium, low magnesium. So those are other things that you would monitor. If you don't correct the magnesium, if you don't think about that, you have to order magnesium separately. On your BMP, your potassium will come. But if you can't get the potassium back up, it's refractory, think about magnesium. If you don't correct it, it's hard to get the potassium to stay up. Hyperchloremic acidosis, high chlorides on your BMP as well. Okay. So monitoring, I think I've hit most of them. Renal function, your electrolytes, and the other would be blood count. So anemia and leukopenia can also occur from these drugs. Question about the conventional. Okay, let's look at the lipid formulations. So there's two of them. Amphotericin B lipid complex, liposomal amphotericin B. Look at the dose on this one, 3 to 6 milligrams per kilo per day. The conventional is 0.5 to 1.5. So if you use the liposomal for the conventional, you will overdose them by what? Up to 4 times as much, too much. So people have done that. So that's why formulations are important to keep in mind. So higher dose with the liposomal. Adverse reactions are different. Their infusion reactions are not the same. You don't see the same things that you do. They're unique. So they are listed under that second bullet. Chest pain, shortness of breath, hypoxia, abdominal pain, flushing, urticaria. But to a lesser extent than you see with the conventional form. You still see electrolyte abnormalities with these formulations, so the potassium, the magnesium, and the chloride, all the same. For the most part, the lipid forms have replaced the conventional forms. So let's talk about the nephrotoxicity, because it's so common. Even with the lipid forms, it still happens. It's about half the risk compared to the conventional. So acute kidney injury, look under that second bullet. You get a vasoconstriction, and then that causes the drop in glomerular filtration rate. That will cause the rise in serum creatinine. Again, risk factors for injury, know these big things. Nephrotoxins, if you give nephrotoxins with this, you'll increase the risk. If they have chronic kidney disease at baseline, and then it's dose dependent. The higher the dose, the more likely it will occur. Cumulative dose, 600 milligrams. So pathogenesis it's the vasoconstriction, and then it's injury to the tubules. So they can't concentrate acid and secrete acid. They keep hydrogen ions. They throw potassium out. That's why you get that potassium wasting. That's why their serum potassium eventually goes down. Prevention we talked about, low doses, lower dose. If that'll work, use that. Don't use other nephrotoxins. Two preventative measures are salt load them. So we give them normal saline before and after. Use the lipid formulations. Or if they are susceptible and can be treated with the IV azoles, use those. So posaconazole, very broad spectrum. So that one could be considered, or voriconazole. It is reversible if you're monitoring and you stop the drug if necessary. If your serum creatinine goes up too high, it's reversible for the most part. Put it back on it, it usually will return. Okay, so questions about amphotericin. Really difficult drug, very effective. Just a hard one. Okay. So the last one is Pneumocystis erovechii, ECP pneumonia. Usually you will see this in very immunocompromised HIV patients who are not treated well, stop their medications. They often, because they get more immunocompromised, if they're off their antiretrovirals can come down with this. I lived in Austin Austin, Texas, when HIV started first showing up, and it was big enclave. We had a very large gay community, and about, I don't know, 82 or so, we started having these conferences. They're like, we're seeing this weird virus show up, and it's in this community, and so I saw a lot of PCP when I was a resident, and I saw a lot of young men die from it. It's a very nasty disease, and the only drug we had at the time was pentamidine to treat it, and it has lots of side effects we'll talk about in it. We had trimsulfa. It's continued to be a very good drug in treating PCP, and that's usually our starting point. So let's kind of look at the overview. The first thing is we classified this. Did you all talk about PCP? So you classified it by mild, moderate, severe. You looked at AA gradients, oxygen. Okay, we'll go through that. For patients who have HIV, you want to know, are you taking your antiretroviral? Are you, and it's ART therapy, that's what they'll call it, antiretroviral therapy, ART. If they've gone off of it, we need to get it restarted. And we're going to keep them on, if we can get them over the initial insult, we will keep them on preventative antibiotics until their CD4 counts come back up. So usually CD4 counts less than 200 and not taking their antiretroviral is usually what puts them at risk for this pneumonia. So the first thing you want to do is determine, do they have an allergy to a sulfonamide, because our drug of choice is going to be sulfamethoxazole trimethoprim, so Bactrim. So empirically, that's what we're going to start if they don't have a contraindication to it. Especially if their CD4 count is low, they're hypoxic, and they've got interstitial infiltrates on chest x-ray. We're going to prophylax them once we get them over until their CD4 counts come back up. The things that we're going to do is we're going to evaluate their respiratory therapy. So we're going to look at their alveolar to arterial oxygenation, their AA gradient. Have y'all talked about that? No? Okay. So the choice of we're going to use an antibiotic. We have alternatives if they can't use a sulfonamide. And then the next is, do we use a corticosteroid or not? So those are going to be the big decisions you're going to make with each of the severity categories. So initial approach. So let's look at mild disease. So the AA gradient, it's less than 35. Normal is 5 to 10. That would be for you all. Okay. So it's looking at alveolar to arterial oxygen. So they're going to be pretty close. They should be fairly close. 5 to 10 millimeters of mercury is normal. So write that down so you can have a comparison. And their partial pressure of their arterial oxygen is greater than 70. Do you know what normal is? Close to 100. So 75 to 100 in there, 80 to 100 is going to be normal. Here we can treat them orally with trimethoprim sulfamethoxazole. We can do PO, we can do IV if we needed to. And look at the amount of time, 21 days. You do not have to know this dose, but you have to know the antibiotic. What's your question? Let me just, what do you need me to repeat?
We were just trying to think about what Dr. McNeil was saying something earlier. We just remember that the partial pressure is something 90, something 94. I don't know.
That's oxygen saturation.
Oh, okay.
Different.
Okay.
O2 sat.
Okay.
So that is above 94%, 94 to 100%.
Okay.
Yes.
Does Bactrim have an antifungal?
No. No.
Oh, it ends in the sulfa.
But it goes after folate. So it interrupts the ability of the organism to use folic acid.
It has azole at the end of it. That's what that's
No, it doesn't have. No. Okay. So alternative antibiotics. So I want you to know the big categories. Trimethoprim, dapsone. Does dapsone ring the bell? Do you know anything about dapsone? What do we use that for? Leprosy.
I was like, I usually like cough.
But that's where it works. It shows up in different other diseases as an alternative. But here it is. It's an alternative. Clindamycin, primaquine. What's primaquine used for? Malaria, anti-malarial. Atovaquone, only used in mild disease, so we'll only do it at this point. Okay. You need to test for G6PD deficiency. So why do we need to do that? Because they can get hemolytic anemia or methemoglobinemia. So that is a problem with dapsone and primaquine, both of them. Now, the risk of that is low, so a lot of people will do the testing and start the drug at the same time, because it will take a little bit to get your answer back. Okay. And there's a picture on the next page just to remind you. I know you just had this in terms of G6PD, the hemolytic anemia, also the where in the cycle it also shows up. So if they have a G6PD deficiency and you got mild disease, you could use the one drug, the atovaquone. Or you could use pentamidine, but those are further down the line. Don't use steroids in mild disease. For moderate disease, you've got an AA gradient 35 and above. Your partial pressure of oxygen has gone down, so 60 to 70. Trimsulfa is still the drug of choice. Alternative antibiotics are the same. Trimethoprim, dapsone, clindamycin, primaquine. Here we add steroids. And I've got a section on the next page about the steroids. For severe disease, you've got an AA gradient of 45 and above, or above 45, and your arterial oxygen is less than 60. These folks are very at risk for dying. They are in severe respiratory distress. Thank you. So here we do IV. So Trimsulfa can be used. If they have an alternative, would be pentamidine. Very effective, lots of side effects. Problem with it is renal insufficiency and pancreatitis. Here, steroids are required.
What did you say was the first line drug? I didn't understand what you said.
Still Trimsulfa. Trimsulfa is across the board,
Sorry.
PO or IV. The sicker they are, the sooner you go to IV.
Yeah.
So it's pretty much the same drugs every time. And then you're ruling in or out whether or not you have an allergy or an intolerance that you have to go to one of the others. Why do we use steroids? Yes? Yes.
Oh,
Yeah.
I don't want to answer that question, but
Oh,
for the steroids,
Yes.
in the moderate, you only use it if you're using an alternative.
okay. No. Did I write that down?
At the
I
very
think the way it's tabbed, it looks.
Oh, I think it's just the way I tabbed it. It's steroids that are moderate to severe.
Okay,
In
so,
both. You would use them in both. Not mild, but the rest of them.
okay,
Okay, so in corticosteroids, the reason we use them is they decrease mortality, decrease the risk of respiratory failure. So we're going to use them in moderate to severe disease. So that just kind of lists it. If their arterial oxygen is less than 70, if their AA gradient is greater than 35. Here's where those O2 sats come in. So less than 92%. That's pretty low. You can start steroids at the same time you start the antibiotic. Some people, if they look more toxic, even though their numbers look good, and they feel like they're more, if they're in impending respiratory distress, will start steroids as well. How long to use? Usually it is a prolonged course, 21 days, and then a taper. So they could be on it for 4 to 5 weeks. Just one thing, that may help the other make sense is that prednisone is a prodrug. So the body methylates it, and we get methylprednisolone. This is a 5 to 4 ratio. So if we had 5 milligrams of prednisone, we would give 4 milligrams of methylprednisolone. That's what that next section is. So like when you do a Medrol dose pack, it's methylprednisolone, the strength is 4 milligrams. If we give you prednisone, it's 5. So that's,
What are the advantages of using
nothing. Outcomes the same. Okay, special populations. Trimsulfa is still preferred in pregnant women. However, when you get later into the 3rd trimester, it will increase bilirubin, and so children can often be born with very high bilirubin levels. Can lead to connectors, which is the effects of the bilirubin on the brain. So we tend to not use it late in pregnancy. In that case, you need specialists to take over that case. Prognosis depends on the degree of hypoxia. So you see with mild disease, mortality rates less than 10%, severe, more severe 20%, respiratory failure 60%. So needs aggressive treatment.
Is this special populations inside the AIDS population stuff?
Yes.
Okay.
Yes. Well, I mean, everybody's colonized with pneumocystis, but usually immunocompetent people aren't going to get it. So I'm assuming you can have somebody who was immunocompromised that didn't have HIV could get pneumocystis. Yes. Okay, so people who are at most risk are older, low CD4 counts, other fungal or other infections that are common in immunocompromised, like here I've listed CMV. So other infections that are coexisting. Monitoring is important because once you've treated them, they've gone home, you're going to keep them on this drug for a while, for at least 3 weeks, I think is the time.
The second bullet says 2 to 3 weeks.
2 to 3 weeks.
This time's per week,
Okay.
sorry.
Yep. Let me go down, because I can cover some of this as we go through the adverse reactions. Okay. Trimethoprim, sulfamethoxazole, you've got to know the side effects that are underneath that, because it's the most common one used. Usually well tolerated. All drugs can cause GI intolerance. Can get a photosensitivity reaction, so if they go out in the sun, they are most likely in sun-exposed areas to have an increase in a sunburn reaction. So they'll burn faster and to a greater extent if they're out in the sun, sun-exposed areas. Rash, fever, leukopenia, marked hyperkalemia, acute kidney injury, hepatotoxicity. These are uncommon in most immunocompetent people, but you can see these worse reactions in these folks. Dapsone, the ones I want you to remember are the anemia and the methemoglobinemia. So remembering that you need to know if there's G6PD inhibition. The clindamycin, primaquine, again with the primaquine, it's that hemolytic anemia and methemoglobinemia. With clindamycin, regardless of what you're using it for, you're putting people at risk for C. diff, higher incidence with that antibiotic. Atovaquone is fairly well tolerated. Look down under pentamidine, lots of side effects. So the big things to remember is that it's nephrotoxic. It's also really hard on the pancreas, so these folks often will get very high blood sugars or very low blood sugars. They can develop a drug-induced diabetes. Walked into a guy's room one time, he had been on pentamidine for a while, couldn't talk to us. drew blood sugars, the blood sugar is 25. So normal is about 100 and up. I saw a lot of people in diabetes clinic that had, where their HIV medications induced diabetes. So want you to keep that in mind. So kidney effects, diabetes effects. Know that it has big effects on electrolytes. Okay. And when I rewrite the objectives, I'll be more specific with those that I just told you. Treatment failure. So if they fail, what do? Well, think about, are there other opportunistic infections going on? Change the Bactrim or from oral to IV. Or think about pentamidine or the clindamycin primaquine. Timing of ART, to me this is important because when I saw patients, HIV patients, invariably they weren't taking their meds. It is so important for them to maintain their immune status, and good immune effect is that they take their medicines. And they're hard because they have to be taken within they're very time sensitive, so they can't be more than an hour or two off of their scheduled times. So it's very important when you see these folks to make sure they're getting back on their medicine. It's also make sure they're getting hooked back up with the person who is managing. Usually these folks will be followed in an HIV clinic. So getting that medicine restarted. So start it back, and you're going to continue them on that medicine in a prophylactic dose until their CD4 count comes back up. And it stays there for, I think, a couple of months is the recommendation, at least 3 months. Okay, so to me that is a very important concept. You ought to circle it and say Latesse said it was important. You restart the ART and you follow it out and you treat them prophylactically until their immune status is returned to normal. So that would be an undetected viral load and their CD4 counts are above 200. The table at the bottom is there as a reminder. I'm assuming Dr. Britton hit some of these. I don't know if he hit the more unusual antibiotics, like Dapsone, probably not. Questions? Lots of stuff. Group big stuff, common stuff together, and learn it that way, and learn it nice. Okay, so when is your SPBL?
Friday.
So when do you do it? Next Wednesday. Okay. All right. So I'll be around next week if you have questions about your treatment for your patient, and then I'll see you. I don't know what we'll do next week, TV and something else. All right, thanks.
Hey, Paul. Give me that orange highlighter. Thank you. It felt like the beginning of the lecture.
Oh, you couldn't listen.
No, I was like, we were going, everyone was highlighting, I'm like, oh, let's grab it.
The same thing happened to me yesterday. I threw my left hand, and I was like, I don't want to interrupt Kate.
Yeah,
so
it's like, I don't
I'm going to
wanna
wait
throw
2
off.
hours, and then